Thanks so much for joining this afternoon. I'm really delighted to introduce Fran Leeton, and it's great to have so many people here in the room and also online. So as you may know, Fran is a clinical psychologist and also senior lecturer at King's College London, having done her PhD at Sussex and then gone to train as a clinical psychologist at King's College London, then gone back and then back again. So is now back at King's College London. And Fran currently has an MRC New Investigator Research Grant and works clinically as well at the Centre for Anxiety Disorders and Trauma in South London in the Maudsley NHS Foundation Trust. And her focus, as we'll hear today, is very much on repetitive negative thinking in the emotion disorders. So I hope you'll join me in welcoming Fran. Thanks so much.
Thank you for a nice introduction and for the invite. It's really nice to see everyone here today. Thank you. So yes, today I'm going to talk about a topic that I've been thinking about for a very long time, which is worry, and specifically kind of why do people worry and why do people worry excessively? So, oh, don't worry. So, before I start talking about worry, I was asked to spend a few minutes talking about my career path as part of the Athena Swan initiative. I was looking at this on the train on the way here and I was like, actually, this should be a really squiggly line. Nobody's career path looks straight, but hopefully I'll give you a bit of a sense of some of the trajectory that I've been on, and also kind of some of the squiggly bits as well. So I started my career as an undergrad at the University of Sussex, and then I went to live in France. So what I would say is that I have no plan, like lots of people do not have a plan at that early stage. And I didn't do anything psychological in France, but I thought I'd put it up here because I did spend some time kind of thinking about what I wanted to do. I learned a new language, and I just kind of, I suppose, felt that it gave me perhaps a kind of better base to come back to do further study on from. And I work with a lot of undergraduates, and they often say to me, what should I do straight after undergraduate? And I know that people have kind of different pressures in their lives, but I think there's kind of lots of different paths people can take. And I definitely recommend that people perhaps kind of broaden their opportunities and go and do other things as well, if that's what you want to do. So once I'd finished in France, I came back to University of Sussex, where I did a Master's in Research Methods and a DPhil with Graham Davey, who some of you might know his work. Graham's become a fantastic mentor and a good friend. He's now retired, but is still publishing, because that's academia for you. I then, in my fourth year of my PhD, got a job as an assistant psychologist, which again was really good for me because I did some really kind of applied research in clinical services. So it gave me a kind of really interesting insight into kind of how we moved from the kind of really experimental work that I did in my PhD to how we actually kind of implement that, if you like, in clinical services. I then went back to Sussex again because I really like it at Sussex, and I was lucky enough to have a 3-year postdoc again with Graham, which was great. We did lots of experimental work, some of which I'll talk about today. And then I got another postdoc at the medical school at Sussex, which really introduced me to a lot of the psychophysiological research, which I've incorporated into the work that I do today as well. So kind of picking up things along the way. I then went to do my clinical training at King's, which took me on to a clinical fellowship. So I had a year's fellowship, which kind of enabled me to think about what I wanted to do and write some grants, which was good. I then went on to get a clinical lectureship, and some of the grant writing paid off, and I was awarded the Medical Research Council grant that I do now. And then I moved back to King's, so I just bounced along the way between King's and Sussex, really, with a little stop in France early on. What I would say is that I think that's a kind of really kind of narrow view of a career path. And certainly all of these lines also represent kind of significant jobs that I applied for that I really wanted, or really significant fellowships that I didn't get. So if anyone is in that kind of ECR space where they're applying for things and it's not hitting, I would just kind of recommend that you keep on, because things will happen. And academia, I think, can be a bit kind of brutal in that sense. So just, yeah, keep applying for things, keep going, if that's the place you're in, and your career will flourish. So where are we today? So this is where I am currently at King's College London. So I am a co-leader of a group called the Cognition and Emotion Disorders and Resilience, the CEDAR group, which I run with Colette Hirsch. Many of you may know her and her work. And we had a team, we took a team photo and then our team got much bigger. So we need to take another team photo. But this is our current team at the moment. And I also work clinically at the Centre for Anxiety Disorders and Trauma. And so at the moment, my post is a kind of real rotation, if you like, between clinical work, academic work and the clinical doctorate, and also my research work as well. So I'm going to take us back 30 years. I actually felt quite nostalgic when I was preparing this talk because I remember reading this paper when I was an undergraduate at Sussex and thinking, oh, well, that's really interesting. They're doing research kind of just on worry. Why would they be doing research on worry? And I remember being really taken by this paper because it seemed to kind of represent a bit of a kind of sea change, really. So Mark Freeston and colleagues were talking about the fact that a lot of research kind of to this point in worry had been looking at the kind of content of worry. So what is it that people are thinking about when they're worrying? And in this paper, they talk about the fact that they've actually kind of started to change a little bit and look at some of the kind of processes that they think underpin worry and some of the processes that I suppose we can also think about underpinning repetitive negative thinking in general. And really, I think this is kind of very much a paper that inspired me to kind of start doing that work as well. I feel like we spent a lot of time in the time between 1994 and now thinking about the processes that underpin worry. And so I just wanted to kind of flag, I suppose, that I feel like this was the point where myself and also a lot of other research teams started to look at these processes. And this is a lot of what I'll be talking about today. So moving on to exactly what I want to talk about today. So I do want to kind of use this talk to think about what are the cognitive processes that underpin pathological worry. And I'll also kind of dip a little bit as well into some of the physiological processes, as that's something we've been looking at more recently. I want to think about how we can use experimental methods. I'm a real fan of the experimental method, but I also think there's lots of things that we can improve. So I'll be talking about some work that we've done in the past, and then also talking about some work that we've literally just finished doing as well. And then I also want to spend the last part of the talk thinking about how we can use the experimental methods, use the processes that we're targeting and trying to manipulate in these experiments as potential targets for treatment as well. And I'll talk about some work that Colette and I have been doing and some work that we are just finishing but don't yet have data for because data takes a long time to collect. So just to make sure we are all on the same page, I just wanted to start off with thinking about kind of what do we mean by worry. This won't be new for many of you, but just to kind of orientate everyone. So when we're thinking about worry, we're thinking about both thoughts and images. We talk a lot about worry being a verbal process, but actually there's a lot of imagery in there as well. And we're talking about things which are future orientated. So something which is yet to happen, but potentially could happen, and therefore is uncertain, and therefore is something that our brains could hook into and really think about the potential outcomes of this as yet to happen situation, which I suppose is really kind of why worry can be so kind of capturing. Something could happen. I can think about this, but I don't know it's going to happen. And as many of you will know, worry is one of the core symptoms of generalized anxiety disorder. And when we're thinking about maybe the difference between kind of day-to-day worry, so the worry that lots of people experience, worry is a very normal and sometimes, dare I say, useful, occasionally, thing to happen to all of us. In generalized anxiety disorder, we're really thinking about this very excessive and very uncontrollable worry. And we also know that alongside worry, there's a number of kind of other what we call somatic or kind of physiological aspects to generalized anxiety disorder as well. People often feel very tense, very keyed up, very on edge, irritable, etc., etc. But for now, I'm going to be talking about the cognitive processes in worry itself. And why am I interested in worry, apart from reading about it 30 years ago and kind of finding it quite interesting? Why do I think it's important that we should be researching worry? So first of all, it's highly prevalent. Again, many of you will know this, especially if you're working clinically. It's underdiagnosed as well when we're thinking about worry and generalized anxiety disorder. Lots of people with generalized anxiety disorder actually don't seek treatment. I often see people by the time they have come to clinic and they'll be saying to me, well, I've been a worrier all my life, but in the last 20 years, it's got really bad. But they might have waited 20 years before they've come to therapy. That might be them, that might be the system, but you know. it's highly comorbid. So we often see people who come for help with panic difficulties or OCD, but have comorbid generalized anxiety disorder as well. And I think one of the things that's often overlooked as well about pathological worry is that there is actually an impact on somatic health. So whilst we don't want to scare people, we know momentary worry is, of course, not dangerous at all. It's a perfectly normal and adaptive response. Momentary stress is a normal and adaptive response. So our bodies can very well cope with this physiological responding to stress. Over time, if we have years and years and years of psychological stress, excessive and uncontrollable worry, then it can start to take a toll on things like blood pressure and things like cortisol, things like heart disease as well. So it's really important to think about the kind of holistic situation that people find themselves in when they've been living with generalized anxiety disorder for a long time. I suppose I also kind of see an interesting research in as well with a lot of this. So we know we have effective treatments for generalized anxiety disorder. CBT does work, but there is a lot of variation in outcomes for lots of reasons. But we do have about approximately 50 people making complete recovery after CBT. And I suppose for me, what that says is that actually there's also scope for us to be either improving the treatments that we currently have as evidence-based treatments, or indeed looking for novel approaches to treatment as well, which of course is a really interesting and exciting space to be in. I'm also interested in what we kind of might think about as subclinical worry, or kind of very high worry in people that might not quite meet a diagnosis for generalized anxiety disorder. So a couple of years ago now, yes, 2022, Graham and Andy Field and I at Sussex published a paper where we looked at Penn State worry scores, so self-report measures of trait worry over 20 years that Graham had been collecting through his work. And what we noticed is that even when you kind of account for covariance and things, worry scores are going up and up and up. And I think there's lots of reasons we might see that. It might be that indeed our students at Sussex University and perhaps beyond are becoming more worried. I can think of the way that student situations changed, certainly in the last decade, as to why this might be the case. It might also be the way we talk about worry. So maybe actually because we talk about mental health in a different way and people are more aware of their mental health, they're more willing to report it. So people have kind of become more comfortable with talking about their symptoms. We don't know because we didn't have the data in the specific paper to look at it. But it does seem to mirror kind of what we see with mental health in general. So this is a report, a very recent report, which looks at increase in mental health conditions reported by students. The same with the worry scores, they're going up and up. And I did just want to add this one as well. This is a paper by Lucy Fox, who works obviously here. And I just saw this this morning, actually, so I popped it in when I was on the train, because I think it's a really interesting kind of conversation. So in this paper, Lucy and her colleague are really talking about the rise in mental health problems. So the same kind of thing that we're seeing with our worry data, but they're discussing why that might be. And I think there's a really interesting conversation to be had about kind of mental health awareness. And is it that people are experiencing much higher difficulties with their mental health, much more incidence of mental health difficulties, and that's what we're seeing? Or is it the way we talk about it? Or is it that awareness is making people kind of feel that they almost kind of have more difficulties? And there's kind of quite a kind of interesting nuance there, I think. And one of the things that I've become very interested in is how we also create accessible treatments for people who might be experiencing this high mental health, like our students at Sussex, high mental health difficulties, but they're not in clinical services. So again, I'm kind of really interested in that space as well around how do we support people who might not come to face-to-face talking therapy, because face-to-face talking therapy is not going to be able to support everyone who needs help, perhaps through alternative interventions like kind of online platforms and things like that, which I'll talk about a little bit later. So back to worry and some of the work we've been doing in experimental space. So I suppose one of the things I'm really interested in, and one of the kind of questions that I've been asking myself for many years, is why do people engage in excessive worry when these events are kind of fairly unlikely to happen and when it causes so much distress? And one of the things we've been looking at, as I mentioned before, is really thinking about the cognitive processes that might be underpinning the maintenance, the development and the maintenance of this kind of excessive and uncontrollable worry. So when Mark Freeston and colleagues published that paper in 1994, saying there was a bit of a sea change in the way people were looking at worry, and they were going to start looking at processes. They were right, because all of these models have kind of sprung up in the last 20 to 30 years, looking at different cognitive processes and emotional processes and behavioural processes that underpin pathological worry. And I suppose really you can kind of distill some of the core processes that are mentioned. Some of these models very much overlap. So there's a lot of kind of information that's the same in each of the models. There's also some core differences as well. But essentially, you can kind of distill at least the cognitive processes in these models down to some kind of key processes or key factors, if you like. And these processes can be broadly thought of as negative biases. So when we're talking about biases, we're talking about processes that come kind of almost out of awareness, if you like. They become very automated and kind of very habitual. So we might have biases of interpretation. So we'll have, for example, a situation which is ambiguous. And if I have a negative bias, so a nice example is you get an email from your boss, they want to talk to you. I don't know how most people might think about that. My brain would probably go to, I'm going to be fired, what was it I did? But you could be thinking, well, that's great, they're going to praise me for the wonderful work that I've done. We also have attentional biases as well. Again, many of you are probably aware what these are, but just as a nice example, I suppose, if I'm someone with a negative attentional bias, I could be kind of scanning the room, looking to see who's asleep, looking to see who looks bored. And it might be that kind of that's where my brain goes, despite the fact there's lots of other evidence of people looking and smiling and nodding. I might kind of ignore that and only kind of take in the kind of negative data, if you like, the negative evidence, which makes me think the world is kind of a more kind of threatening place than perhaps it really is. The other kind of core process is metacognitions. And again, this is a really broad term for some quite kind of specific examples that are in the different models, but I've just pulled out a few of the examples. So metacognitions, as again, I'm sure you're aware, it's kind of thinking about thinking. So within worry, there's quite a bit of research which suggests that people actually have positive beliefs about worry, which lead them to not try and not worry, but actually engage in worry. So lots of people with generalized anxiety disorder report thinking, well, actually, I do want to think about this worry because it's kind of perhaps important, I should think it through, maybe there'll be something useful that comes out of it. So they have positive beliefs about the kind of nature or purpose of worry. And another kind of key process is negative beliefs about uncertainty. So certainly many of you are probably aware of the intolerance of uncertainty model within generalized anxiety disorder. There's a wealth of evidence which suggests that people with GAD and high levels of worry really find uncertainty difficult to tolerate. So a good example would be this morning, I got the train from Brighton. There was an outage on the train system, pretty much everything was cancelled, and I had to sit with that, like, will I or won't I get there? Should I email Kathy? Should I get a taxi? What should I do? And you have to really sit with that uncertainty. And different people will manage that differently. Some people will find it intolerable to not know if they're going to get to the talk they're going to do. Other people might just kind of think, well, you know, I'll just see what happens, what will be, et cetera, et cetera. So you can see these kind of, I guess, the way that these kind of core processes, if you like, kind of intolerance to uncertainty can kind of affect, depending on how much we engage with the intolerant, how much we experience intolerance, can really affect how people worry. We also have what's called attentional or inhibitory control, and this is more what we call a kind of top-down process. It's the idea that if a worry or a kind of perception of threat comes into your mind, how well able are you to pull away from it? Do you engage with it to begin with because you have positive beliefs about worry, but then wish you hadn't and find it difficult to disengage from it? So this process, again, is very much a process we see as being relevant to how long people might end up worrying for, whether they're able to stop worrying when they want to. And the final process, which features in a lot of these models, which I'll talk about a bit more later on as well, is we've labelled it mentation style, but essentially it's kind of this idea of whether worry is a verbal process, so this kind of what if, questioning style, what if this happens, what if that happens, what if, or a verbal process or a kind of imagery process, which can really, I suppose, kind of create quite a kind of fast emotional response when we have a very fast negative image that comes to mind, especially if it comes out of the blue as well, and that can then lead us to engage in worry. So as I mentioned, they're kind of some of the processes that are kind of common across a lot of those, or all of the models of worry I put on that slide. And what we can do is kind of broadly put together a bit of a a diagram that shows us how these things might interact. And this is based on a paper that Colette Hirsch and Andrew Matthews published in 2012. And then kind of I've added a bit on, essentially, based on a paper that Graham and I published in 2016. So I do think there's a bit more evidence to support some of the extra features as well. But essentially, you can see that we have kind of the kind of involuntary negative processing biases, which, as I mentioned, can happen outside of our awareness. They can kind of bring representation of threat into the fore, so they make us kind of feel like the world is a more threatening place. And once we experience the sense of kind of a threat, or it could be an image, sometimes it can be verbal, but oftentimes people talk about it as a strong negative image. We have our metacognitive beliefs, so if we think worry is an important thing, or if we find it very difficult to tolerate uncertainty, we might end up allocating attentional control, so allocating our top-down attention towards that worry, thinking actually this feels like an important thing to think about, maybe I should just consider this. And then what happens is people often find it very difficult then to kind of get out of that worry cycle. And we end up over here in this protracted cycle of worry where we end up thinking, what if this happens? What if that happens? So I put a kind of bi-directional arrow here as well, because what can happen is we see this kind of bounce back between negative imagery and worry. If we think about that process, I guess one of the things that I'm really interested in is if we know that these processes are important, maybe we've done some experiments to show that these processes are important with worry, maybe we've also done some surveys, we've captured this information. For me, this provides us with good information about how we might start to interfere in this cycle. So can we change processing biases? Can we change people's beliefs about worry? Can we change people's attentional control allocation? Or indeed, can we change this relationship between verbal worry, the kind of what if worrying, and imagery? For me, this is all opportunities to think about ways that we can almost kind of have targets, if you like, for interventions, or at least explore the opportunity for targets for intervention. So when I was doing my DCLIN side, I was interested in what we really knew about the causal relationship between these types of factors that we know are important in pathological worry and their relationship to worry itself. So I did a systematic review, and arguably you could say it was quite a kind of narrow review in that I was kind of really wanting to look at experiments. So there had to be a process that we know is relevant to pathological worry, so like intolerance, uncertainty, like biases, negative biases, attentional control, etc. And it had to be manipulated because it's an experiment. And there had to be, the dependent variable had to be a measure of worry of some sort, kind of within the experiment. And I was surprised because I found really few papers. And actually we're just updating this. Like, as I said, I did this for during my DCLIN. I didn't quite push it over the line with publications, so now we have to do it all over again. But nonetheless, it'll be interesting to actually look at this afresh, just to see if there's been an explosion maybe of experimental work. We don't never know. I'd like to think so, but I kind of suspect it might actually not be that different. And so I guess it kind of leaves me wondering kind of where is our experimental work with these processes? Is it that actually just not that many people are interested in experimental psychopathology and we should be doing more experimental work? Is it that loads of people have tried to do this and it all kind of ended up in that kind of murky space of publication bias, which I suspect I might be right on? I don't know, I suppose, but I think it's really interesting to think that actually kind of experimentally, and I know we're looking at quite a kind of narrow set of experiments where there had to be a dependent variable of worry, but experimentally we know very little about the kind of cause and effect in these processes. What I thought I would do is just take you through a couple of studies we've done. One I did quite some time ago, but is a kind of true experiment, if you like. And the other one, which we've done very recently, which is not yet published, which is a kind of, it's not a true experiment, but I guess it's kind of quasi-naturalistic experiment. I'm just going to keep an eye on time as well. Okay. So I'm going to talk first about a study we did on intolerance and uncertainty. So this is a classic single session experiment. I'm going to speed up a little bit so I've got time to get through everything. So just as a quick kind of recap, So intolerance of uncertainty and generalized anxiety disorder, people experience uncertainty as unacceptable, as very distressing, and overestimate threat in uncertain situations. And we know that this is associated with diagnoses of GAD, but I was interested to know whether this was associated with worry in the context of a single session experiment. And of course, because this is an experiment, we need to think about the experimental method. So of course, to do any experiment within the field of experimental psychopathology, we need to be able to accurately measure the construct of interest. So here, intolerance, uncertainty. We need to be able to manipulate that construct, which I think is interesting and sometimes very difficult to do, which might be why we don't have many experiments in this topic. We then, assuming we can manipulate it, we need to assess that we have indeed manipulated it. So we have to assess what we call near transfer. So that's after the experimental manipulation, do we actually have a change on the thing we said we were going to change? So have we changed people's self-report of intolerance and uncertainty? And then we need to have far transfer as well to show that we've affected worry, our key variable of interest. So all of these things obviously need to go into our experiment. So what we did in this case is we had analog population. So we invited some students to take part in our study. And we took baseline measures of intolerance and uncertainty. So we used validated questionnaires, as you'd expect. And we also took, as well as taking trait measures, we took some state measures as well. So kind of in the moment, how do you feel in terms of intolerance and uncertainty? And then we randomly allocated people to a high uncertainty group and a low uncertainty group. And then we have to do our manipulation. We did this manipulation because it had been, someone else had done the manipulation, it looked to be effective. But I think it's always interesting when we're looking or thinking about how actually we do manipulate these constructs, which are quite kind of ingrained within people. And kind of, I suppose I'm always interested in thinking and talking about the kind of efficacy of that and how we might do that better. So in this case, for the manipulation, we asked all of our participants to read a story where the central character encounters an uncertain situation. Half our group were randomized to experience a version of the story where uncertainty is experienced as acceptable, and half the group experienced a story where uncertainty is experienced as distressing and threatening. We asked people to read the story and really think about the motivations of the central character in the story, really kind of paying attention to how the character responded. And we then asked people to spend about 15 minutes writing a diary as though they were the character in the story they'd read, describing how they'd feel, describing what it'd be like to be that person, and really essentially kind of trying to get people into the kind of headspace, I suppose, and the kind of emotional feeling space as well, of not being able to tolerate uncertainty or finding uncertainty kind of fine and unthreatening, essentially. So we did our manipulation, and then we did a manipulation check, where we took 3 visual analog scales, so just to kind of in the moment, how do you feel, which was obviously the same measure we took at baseline, so we could see if we had this near transfer. And we also undertook a behavioural worry task. So this is to assess our far transfer. So we used a task which has been used many times before, which is the catastrophizing interview. And so in this interview, you ask participants to really think of a current worry, and you ask them to kind of downward arrow into that worry a bit, and you get them to sit and think about it for some minutes. And then you ask them, what is it that worries you about that? So for example, if somebody had come up with the worry, what if my bills go up and I can't afford them? We might say, it might sound obvious, but what is it that worries you about that? And they would give a response. And essentially you keep going. Whatever they say, you ask it back to them. And people end up generating a surprisingly high number of steps. And the number of steps, the kind of responses they give you, is your dependent variable, essentially. It's the number of worry steps. And so what did we find? So we found that the group who'd had the manipulation to have their uncertainty increased, or their intolerance, I should say, to uncertainty increased, did indeed report higher levels of uncertainty. So we had our near transfer effect. On our behavioural worry group, we did see the high IU group generate more worry steps than the low IU group. These are standard deviation bars, I should add. So there is a lot of variance around the mean, but we still had a significant difference. And we also found that if we include baseline worries, so people's Penn State worries scores as a covariate, the effect remains. So broadly what we're seeing here is that we were able to see an effect of near transfer and far transfer, and see a relationship between manipulating uncertainty and increasing people's worry in the lab. And so it does seem that we can use experimental methods to manipulate beliefs of uncertainty, and that this seems to lead to increased worry in the moment. And we do, of course, have kind of what we call convergent evidence, I suppose, in terms of kind of real life evidence, real life clinical evidence of where we have treatments for generalized anxiety disorder using the intolerance of uncertainty model. We see that it has large effects in terms of recovery as well. So whilst there's lots of other things that goes into a CBT approach with intolerance of uncertainty at its core, so lots of other non-specific factors, as we call them, in relation to therapy outcomes, it does seem to be that if we look at modifying intolerance of uncertainty in the therapy space, then we do also see it has a good effect on reduction of worry as well. So it does indeed seem that this is an important factor in relation to worry. So what do I think about the future of this experimental work? So, I mean, I would say this, but I think we should do more of it. I think we should do more of these really nice, tightly controlled experimental methods. I also think we should address the publication bias. And I just wanted to give a quick shout out to Nathan, who's a PhD student of mine currently. So Nathan's just got his stage 1 registered report accepted. And if you haven't done a registered report or if you don't know about it, I do suggest you look into it. So I won't spend time talking about it too much, but essentially what happens is that if you get your stage 1 accepted, it's could be an experiment or a piece of research you propose to do. Once it's accepted, assuming you then run that study, you are guaranteed to have it published in a journal that signs up to this peer community and registered report. So it's a really nice way of addressing publication bias. And Nathan's actually doing a registered replication as well, which I'm particularly proud of, because I think we should also be trying to do more replication work in the kind of, I guess, the kind of space of thinking about now we've updated our methods and now we're kind of applying perhaps more kind of rigorous approaches than we might have done 30 years ago. I mean, the field has moved on. Do we also see the same effects? Can we replicate the work we did all that time ago? That feels really important as well. So I'm going to move on to talk about some work that we've done more recently. I would call this it's not an experiment as such, because it's kind of more naturalistic perhaps. But I'm going to talk about the role of imagery in worry. And this is research that my colleague Carla Dance led on. So Carla was a PhD student at Sussex University, and she specialised in aphantasia for her PhD. But she's also developed an interest in mental health and has actually just started on the clinical doctorate at King's. And she has led a piece of work where we explored the role between imagery, worry in aphantasia. So before I talk about aphantasia, I'm just going to talk a little bit about imagery and worry. So again, many of you might be aware of this, but we know, for example, with Borkowicz's cognitive avoidance model, that in worry, it's kind of assumed, or the models propose, that threat perception is often in imagery form, and this brings on a really strong kind of emotional and physiological response, and that negative imagery is perceived to trigger verbal worry. So it's often assumed to be a kind of very strong negative image that might kind of signal threat perception and then kind of spiral people off into worry. This worry is often in a verbal form, as it's reported to be, but people often report also kind of coming back to strong images as well. The more worried you get, the stronger the images become, and you're in a bit of a feedback loop. And so we were interested to know kind of if we can reduce imagery, is worry also reduced? I suppose I was coming from a kind of causal, a desire to kind of know cause and effect. But Carla proposed that actually, you know, she works with these people with aphantasia, which is an absence of imagery. So can people with weak or absent imagery also experience worry? It's another way of kind of looking at the same question in some senses. And so what we did is we looked at worry with an aphantasic population. So just to bring people up to speed on aphantasia. So aphantasia is the absence of visual pictures in the mind's eye. So actually some people might experience really, really clear visual imagery. So this is Brighton Beach. But other people might experience it as a bit more dim, or indeed kind of very dim, or indeed totally absent. And there's a real kind of variation. The prevalence of aphantasia, which is, I suppose, can really be described as either completely absent or at best kind of weak imagery, is prevalent in about 3.9% of people. And there is some research that shows that people with aphantasia have less physiological fear responses when asked to kind of look at fear-evoking scenarios. But there's very little known about aphantasia and worry and anxiety. So we did a study where we recruited people with aphantasia and non-aphantasic controls. And we took a load of worry measures and anxiety measures, essentially, so took some baseline measures, worry, anxiety. The STICSA is a somatic and cognitive measure of anxiety. We also measured contrast avoidance as well. And we did the catastrophizing interview again. We did a slightly different version this time. So we wanted to give everyone the same worry to kind of try and control for people having different worries, some which may be more worrying than others, etc., etc. So we asked everyone to worry about going to a new town. And we looked at our dependent variable in that way. So just asking people, what is it that worries you about that? When they gave their answer, what is it that worries you about that? And we also asked people about the perceived threat of the worries that they were thinking about at the time. So how concerned were they? What was the likelihood of that threat? What would the cost be and how would they cope? So what we found is that the aphantasic group, so people who have very weak or absent imagery, did worry less when it came to the catastrophizing task. When a behavioural measure of worry in the moment, they were worrying less. They also rated worry as less concerning and less costly. But there was no difference in perceived likelihood of the worry, no difference in coping or solvability. We did find that the aphantasic group had less cognitive, or reported anyway, self-reported, less cognitive avoidance. So actually across all of the different aspects of the cognitive avoidance questionnaire, distraction, substitution, suppression, threat, and transformation, the aphantasic group were lower than the non-aphantasic group. But interestingly, we didn't see any other differences. So there's no difference on the Penn State Worry Questionnaire. So we saw behavioural differences in worry, but no differences on our self-report measures of traits worry. And we saw no differences on any of the other GAD anxiety questionnaires either. So I suppose we can summarise by saying that it seems to be in this initial study, and I think this is probably certainly the ones that we know about anyway, to look at imagery and worry in an aphantasic population. It seems to be that absent or weak imagery is associated with less state, but not trait worry. There was less self-reported cognitive avoidance. And this does perhaps provide positive evidence, working with this population anyway, that imagery is a catalyst to kind of worry and avoidance strategies. And we were wondering as well whether these findings relate more to perhaps the kind of impact of worry, so kind of how people feel perhaps kind of during worry itself rather than kind of worry frequency. I suppose trying to kind of pull apart why you might have seen those differences on the behavioural task and the self-report measures. Although we have found in other studies relating to things like attentional control that actually there seems to be a complete there's a lot of disparity between how people self-report they are at things like attentional control and how they behave in a behavioural task. So maybe there's a bit of that coming into it as well. So, okay, I'm going to move on to the last kind of section of the talk quite quickly. And so I suppose I want to talk now about kind of what can we do about this. So I'm really interested in how experimental work can support new interventions. And I just thought I'd give you an overview of, I suppose, a piece of research where I feel like, I mean, this research has been led by Colette Hirsch, and I was lucky enough to be involved in this particular study. But this is a really nice example of how we've taken a cognitive process that we know is involved in worry. So this is looking at negative interpretation bias and how we've developed it as a platform for intervention for GAD symptoms. And Colette and her team, over many years, have done a lot of experimental work, a lot of those kind of single session experiments, set up in exactly the way I showed you the intolerance and uncertainty study was set up in terms of needing a true manipulation and looking at near and far transfer. And they found in their single session studies that interpretation bias, if you manipulate negative interpretation bias, and if you train people to have a more positive bias, in the experimental studies, it does indeed affect worry in that moment. And so what Colette's done is a really nice example of taking that and expanding it out into the clinical space, but doing it on a online platform, so that actually we also create something which is really accessible and has a lot more reach as well. So Colette's studies, or the specific study that we were both working on, looks at whether multi-session online training, so multiple sessions of training people who have generalized anxiety disorder to have a more positive interpretation bias, does this affect symptoms of GAD? And is this change maintained at 1 month or 3 month follow-up? So are we seeing kind of real meaningful clinical changes by modifying these processes that we know are involved in pathological worry. So this was some research we did with community volunteers, but everyone had a structured clinical diagnostic interview, so everyone had a diagnosis of generalised anxiety disorder, and it was still set up as an experiment, so participants were randomised to receive either positive interpretation bias training or an active control training. And the training consisted of listening to a number of scenarios. So with the positive training, or benign training as we sometimes call it, participants listened to a scenario which was ambiguous up until the end of the scenario. So just like I mentioned earlier about your boss sending you an email, in this case, it's an ambiguous scenario about completing some tutorials online. You know how much effort you've put in, and in the end, it goes very well. But of course, it could have gone badly. The whole point is it's always disambiguated in a positive way, and people see multiple different scenarios related to multiple different worry topics in this training. And then we also have a nice control as well, where people see similar scenarios about similar topics, but they're always left ambiguous. And this is something that people did online, so they did this at home, and they did 10 25-minute sessions over 3 to 4 weeks. We had a baseline assessment, and then we had an end of sessions assessment, and then as I mentioned, we had a 1 month and a 3 month follow-up. So I just present some brief findings. So what we found when we're looking at Penn State worry scores is that this is baseline and this is after the training, and then 1 month follow-up and 3 month follow-up. So we actually see that our group who had the positive training, so this is the orange group here who had the interpretation bias training, their anxiety scores or their worry scores dropped far kind of to a greater extent than the control group. Interestingly, the control group scores also dropped, which we might expect to see when people are engaged in kind of any kind of experiment, I suppose, or any kind of study where people think they might be doing something useful. But we did get these nice significant differences at each time point to suggest that the interpretation bias training was kind of giving people something specifically extra that meant their scores were significantly different than the control group. So we see good effect on this with this training on worry scores. And then broadly you see the same on GAD scores as well. So people's GAD scores dropped in both groups again, but more so in the group that received the positive training. So just thinking kind of about what we can kind of sum up from this kind of like, what can we do about pathological worry? What can we do about generalised anxiety disorder? So certainly we can use single session experiments to identify causal mechanisms of worry. And as I've just talked about, these can provide useful targets for intervention. And then indeed, we can also kind of develop multi-session interventions. There's no guarantee it's going to work, of course, when we put it on this type of platform, but we can at least try to develop these knowing they're based on experimental evidence to suggest that there is a cause and effect in these processes. So just very briefly, I'm going to talk quickly about what other processes I think might be underpinning pathological worry and how we can use these as targets for intervention. So this is work that's really ongoing at the moment in my lab. So we've been looking at the idea that we've actually, for excessive and uncontrollable worry, we've got some good evidence about the processes that we think underpins worry. We've got some really nice examples of how we can use this as targets for intervention. But what about these other symptoms that we know people with generalised anxiety disorder experience? Might they be targets for intervention as well? And so one of the things we're doing is looking very much at some of the physiological experiences people with generalised anxiety disorder also have. So we've known for some time now that people with generalised anxiety disorder experience a lot of tension, experience what you might call a kind of undifferentiated threat response in terms of high levels of heart rate. Borkovet called this defensive freezing, so this idea that people with generalised anxiety disorder are kind of having a kind of chronic physiological stress response. And this has been linked to a kind of deficiency in parasympathetic tone, so that part of the central nervous system that's kind of called the rest and digest. The kind of hypothesis is that actually in people with generalised anxiety disorder, they are very much in a kind of fight-flight response rather than a rest and digest. And this has been associated with acute worrying. So what we're doing at the moment in my lab is looking at whether we can actually modify this parasympathetic nervous system deficiency by increasing heart rate variability. So heart rate variability is an accessible measure of the parasympathetic system. It's used very often now in research because it's so accessible. So many of you might be using it in your own research. And it's also been associated with chronically low heart rate variability has also been associated with anxiety, with depression, and specifically with worry. So with that in mind, what we're proposing to do is actually increase heart rate variability via respiration. I won't go into this too much in the interest of time, but certainly we know that depending on the rate of respiration, so your breathing rate, we can actually modify heart rate variability. So when we breathe kind of particularly slowly, so roughly 6 breaths per minute, but actually everyone has their own individual rates, we achieve what's called resonance frequency, which is where we get a maximization of heart rate variability. As we breathe in, our heart rate speeds up. As we breathe out, it slows down. And when we get to this specific kind of state of resonance, sometimes called coherent breathing, then we maximize our heart rate variability. Prior research has shown that if you do heart rate variability biofeedback, so you train people to breathe at their specific resonance rate, then actually this does have good effects for some physical health difficulties. There's some research showing this for anxiety, but a lot of the research showing this for anxiety is in kind of, I suppose, not in clinical groups, and also some of the research has been very underpowered, very small sample sizes, maybe no control groups, etc., etc. So it's kind of ripe for some really, really tight experimental, clinically applied research. And it's not been done in GAD as well, which of course is a crucial component here. So what we're proposing to do is look to see whether we can do a really nice experiment, looking at the causal relationship between increasing heart rate variability and improved executive function and worry. There is some evidence to suggest this should be the case, but as I said, no one's done it yet. So we're currently working on a single session experiment where we're looking at people with very high levels of worry and GAS scores, and then we'll measure their respiration, we'll measure their heart rate variability, we'll modify their heart rate variability via modifying their respiration, and then we'll look to see whether that affects clinical outcomes and cognitive function as well, with the potential to go on to look at this more in a kind of clinical intervention space, should our single session experiment prove effective. So, in conclusion, we have learned a lot about pathological worry in the last 30 years. I've learned a lot. I think the field has learned a lot as well. I would say that I think experimental work is crucial, and I don't think we're doing enough of it in the field. So I would be a kind of willing kind of flag waver, I suppose, for further experimental work in this area. I do think we need further well-designed, careful experimental work as well to help us develop novel interventions. Right, I will leave it there. Thank you very much.
Thanks so much, Fran. I know we've already got a couple of questions online, but I'll start with the room, and we'll just start with students and early career researchers. Any questions that you might have? Yes.
Hi, thank you for such a nice talk. I was wondering how much you think that different types of medication might be a challenge for how we measure worry. So sometimes sort of less of a verbal worrier, how actually testing them on the sort of catastrophizing interview might actually be a problem.
Yeah, that's a really interesting question. I suppose I've been wondering about that around imagery as well. Now I know that aphantasia is something that people experience. How might that affect our measures? And in some respects, I'm going to say kind of, I don't know, as in I don't know kind of to what degree, but what I would say is that I think we're beginning to think far more carefully about whether somebody is worrying in verbal form or imagery form and what that might do. So I would say that although I don't think we're kind of taking that into account at the moment, I think we're certainly more aware that there might be these different processes going on. You might be aware of some of Colette Hirsch's work where she does some really nice manipulation work looking at whether if you have people who are worrying verbally and you ask them to try and actually kind of turn that verbal worry into an image, you actually saw that the kind of overall in the moment worry reduced. So something about that kind of concreteness of the image that had been verbal. So it's certainly something that people kind of can do. They can flip. So that's kind of an interesting construct as well. But yeah, it's interesting.
Thank you so much for a great talk. I think I had a question similar to hers. Do you know for people who have language dysfunctions, for example, if similar to aphantasia, do they perhaps then, you know, worry less, or like, is there any work with people who have basically like language problems and how that relates to worry?
Another great question. I don't know. So it's a really good question. I'm not aware of any research that has looked at that. So I suppose you're getting at the idea that like if you don't have this kind of almost like kind of what if process going on in your head, then how might that be different? Yeah, it's a great question that I don't have an answer to. I'm not aware of any research in that area.
Yes.
I would ask, is there any predictor of worry, like personality or some other character?
So, I mean, so when you say personality, I suppose we could be thinking about some of these, it depends what we mean by personality, I guess. But certainly we know that of people who struggle, like I was talking about with uncertainty, that can feel like kind of quite a personality type trait. I'm somebody that really finds uncertainty distressing. I'm someone that really kind of struggles to sit with that. And so certainly I would say that's a kind of personality trait of someone who might struggle with worry. Were you thinking of kind of how easy these things are to kind of manipulate, I suppose, when you're thinking about personality traits? Or?
Yeah, I was thinking how before falling in pathological perspective, is there any kind of factor that can trigger perhaps worry, like anxiety or psychopathy or something?
So I would certainly say that lots of people can have a tendency towards maybe kind of trouble dealing with uncertainty or a tendency towards negative biases, and there can be then, I guess, a kind of a point in someone's life where something happens and those things become all the more difficult to manage. So I guess that's, you could say there's kind of, sometimes people have these personality traits, but it doesn't mean that they would develop generalized anxiety disorder. Then there might be a kind of turning point where something happens, then it just becomes much more difficult to manage. I would certainly say that just like worry is on a continuum, and all of us have the ability to travel up and down that continuum depending on what's going on in our lives and where we are and what stresses we have. So I would say the same about our ability to manage the things that we know contribute to worry. So my ability to manage uncertainty and my tolerance to it might be different depending on what's going on in my life as well, and how much uncertainty I've got to manage or what other stresses I have. So I certainly think there can be kind of factors that we know contribute to worry, which don't necessarily mean you have pathological worry, but we can all end up kind of changing along that continuum, which might contribute to then a diagnosis or kind of clinical levels.
Yes, only I think that was. Yes, great.
Well, thank you for your insightful talk. And because it's very common to see patients start and mobile with depression, so I wonder if there need to adjust the treatment to that or things to consider.
Yeah, that's an interesting question. So we might, if somebody has a diagnosis of or come to us experiencing generalized anxiety disorder, but also a lot of depressive symptoms, I certainly would probably be thinking about kind of the factors that underpin those things, which we would think about as repetitive negative thoughts. So certainly we can think of worry as a repetitive negative thought about future events. And we can think of a lot of the kind of thought process in depression as repetitive negative thinking about kind of past events, that kind of ruminative type thought. So actually, I would argue that you could then take a similar kind of approach in terms of kind of looking at that the repetitive nature of the thinking rather than necessarily the kind of temporal thinking itself. Yeah.
Are there any effective interventions for changing the negative attentional bias?
Yeah, that's a good question. Not that I'm aware of. So attentional bias, sorry, I was thinking of attentional control.
Or, yeah, attentional control.
So well,
Same thing.
no, so attentional bias so attentional bias we would consider to be more one of the kind of involuntary biases that kind of can create threat perception. Attentional control is kind of once threat has occurred, where do we allocate our attentional resources to? So a bit more of a kind of executive or inhibitory function. So in terms of attentional bias or attention bias, there's some evidence that you can modify attention bias, but the short answer is the field is crowded with different views. And I think we need some kind of really strong reproducibility work and really strong there's lots of strong experimental work already in that space, but I do think there's a lot of debate about kind of the transfer effect, if you like. You can change attentional bias, but to what degree does that affect anxiety and worry? Attentional control is much harder. There's been lots of people that have done work in that field, and as far as I'm aware, you can change attentional control, but what you often don't see is the knock-on effect, so the bar transfer effect. So when you train people to kind of increase their attentional control, they get better in the task they're doing, but as far as I'm aware, it doesn't seem to have much transfer to actually kind of worry. So there's still a lot of work to be done in that area, but you know, that means there's a lot of promise as well, so.
Just going to go to the online, a couple of online questions, and we'll come back to the room to anyone who wants a question. So, first one is, in your uncertainty manipulation experiment, can you use the baseline data to see if the high intolerance uncertainty condition increase worry and the low intolerance uncertainty condition decrease worry, or both? So do you know, is it that, is the high?
Yes.
Is one going up, one going down, or is one, you know, basically it's which is, or where the.
So we only have the measure of worry at one time point. So we have the measures of uncertainty at baseline and after the manipulation, but we've only got one measure of worry. So we can only really tell after manipulation what's happening. So we couldn't, yeah.
Okay, I think that might answer the other question here as well, which is, it said the experimental method in relation to that same task sounds quite like Socratic questioning. I wonder if you have repeated the baseline, all the repeated measures, sorry, if you've repeated all the baseline measures after the interview and if they were different.
Yeah, I don't know, but yeah.
Okay, so back to the room. Any other questions? Okay, yes, Alex.
I'm just wondering, do you feel that people with aphantasia are is that a protective factor for all sorts of anxiety disorders? That no imagery is present and thought to be caused with a range of virtually all anxiety disorders, really. So, what would you hypothesize?
So, yeah, I mean, it would be very much a hypothesis. I feel like there's been some work done in PTSD, but I looked for it yesterday and I couldn't find it. So that's not an answer to your question, but I'm kind of curious. But as far as I know, there's not been a lot of work done in aphantasia and mental health difficulties. I would wonder if there is a kind of protective factor. I mean, clearly people in our study who have aphantasia still experience worry. Obviously, we didn't find an absence of worry. But there did seem to be, at least as we saw, kind of some differences on the behavioural worry task. I've been wondering how that would look in social anxiety, where we know that worry is the imagery is a really, really kind of key aspect, especially that kind of pre-event imagery where you're really kind of thinking about how you might look, and then also the post-event processing, right, as well, where you've kind of got a really strong picture of yourself standing up, giving a talk, and you're really mulling on how you might look afterwards, all of those kind of things. And I almost feel like kind of imagery could be a bit of a stronger factor in something like social anxiety difficulties rather than kind of diffuse and generalized worry. So I don't know anyone that's done that work, but it would be very interesting. I would hypothesize maybe. Yeah, that's not really an answer, but yeah, maybe. We shall see.
Huge apologies, we're not going to get to all the questions online or in the room. I did want to just say, it's very kind of you to put up Lucy and Jack's paper. They're both sitting at the back, so I don't know if you guys will wave in case anyone's interested in hearing more about that program. So Lucy shouldn't wave, but there's really work. So if anyone wants to chat about that, yeah, I'm volunteering you. And I also want to say massive thanks to Anne-Marie for all of the organisation. Everything's gone super smoothly. And finally, of course, huge thanks again to Fran for such an interesting talk. Thank you.